Good afternoon or good morning, everyone. Welcome to this special webinar hosted by the Canadian Public Health Association in collaboration with the Canadian Partnership for Tomorrow's Health, also known as CanPath. My name is Greg Penny and I'm CPHA's Director of Programs, and I will be your host today. I want to start by acknowledging that while we are all coming to this webinar from different parts of Turtle Island, CPHA's offices and my home are located on the ancestral and unceded territory of the Algonquin Anishinaabe people. CPHA is committed to meaningful truth and reconciliation with all First Nations, Métis, and Inuit peoples, and to that end has established an Indigenous Advisory Council to guide its path towards reconciliation. So a few housekeeping notes before we begin. Today's webinar is being recorded and will be available on CPHA's YouTube channel. All registrants will receive an email containing the link to the recording once it is available. For questions, please pose them in the Q&A module, which is at the bottom of your screen and not the chat module. And now it's my pleasure to introduce Dr. John McLaughlin, Executive Director of CanPath. John returned to CanPath as Executive Director in 2018 after being one of the founding directors who launched the initiative more than a decade ago. He is a professor of epidemiology at the University of Toronto's Dalai Lama School of Public Health. And as CanPath's Executive Director, he leads the National Coordinating Center based at U of T. John, the floor is yours.
Thank you very much, Greg, and thank you to the CPHA for joining us in this shared presentation today on the Canadian Partnership for Tomorrow's Health. So I'm here at the University of Toronto, where it's a great pleasure to introduce our speaker today, Victoria Kirsh. Dr. Kirsh, I've had the great pleasure to work with and witness the progression of her career over many years. She started with her bachelor's degree at McGill in immunology and microbiology, did a master's degree at University of Toronto in epidemiology, her PhD at Yale University in epidemiology. And then we also worked together at Cancer Care Ontario, where she was a scientist and an assistant professor in the Dalai Lama School of Public Health. And now she continues this work, which really builds on her many years of really excellent cancer epidemiologic research. And indeed, I credit Vicky as being one of the co-founders of the Ontario Health Study with me, as much of her effort really helped Ontario Health Study get launched. So I'm delighted that now through the OICR, she's now part of the Ontario Health Study team. And Vicky, I'll turn it over to you for your presentation. Thank you again for presenting to us today. And later on, I'll help respond or sort of chauffeur the question period. So if people want to place a question on the chat, we can address those later. But over to you, Vicky, and thank you.
Great, thank you so much, John, for that kind introduction. Welcome, everyone. As you know, I'll be talking today about CanPath's COVID-19 research initiative. Next slide. CanPath is a consortium of 7 population-based health cohort studies across 10 provinces with over 330,000 participants. It's short for the Canadian Partnership for Tomorrow's Health. The 7 regional cohorts stretch from BC to the Atlantic provinces and are each named here. The Manitoba Tomorrow project recently joined, and a Saskatchewan cohort is in development and will complete the provincial CanPath map. Close collaboration between cohorts provides a coordinated interdisciplinary approach to tackling important scientific questions and offers opportunities to quicken the pace of research. Next. A broad range of data are captured, serving as a resource for conducting data and biospecimen-based investigations of environmental, lifestyle, clinical, molecular, and genetic factors associated with cancer and other diseases. And it's also a resource for conducting health services research. The scientific challenge to better understand all of the factors affecting an individual's health requires a combined effort of epidemiology and genetics and large sample sizes for sufficient power. And that's what CanPath offers. The data collected are harmonized to the extent possible across the provincial cohorts and with other national and international initiatives. Next. A strength of the program is that data linkages let us evaluate our cohort in real time and participants have consented to linkage to administrative health databases. So upon enrollment, health insurance plan numbers were requested to enable high quality deterministic record linkage. But even when insurance numbers are missing, if participants consent to data linkage, we can use several non-unique variables, such as date of birth, sex, postal code, to statistically estimate the likelihood that multiple records are for the same individual. These databases include public health agency testing results, which allows us to capture lab test results. And I'll show you how that's particularly relevant in the context of COVID-19. We can also capture vital status, cancer diagnoses, health services use, including hospital admission and discharge information, and treatment records. CanPath has also partnered with the Canadian Urban Environmental Health Research Consortium, known as CANU. And CANU has built a database of environmental factors such as air quality and amount of nearby traffic, access to green space, for example, dating back to the 1980s for each postal code in Canada. And this environmental exposure data has become part of the CanPath database. Next. Many researchers have paused or pivoted their research projects in response to the COVID-19 pandemic, and CanPath was no different. As a population-based cohort study, CanPath was able to leverage existing infrastructure to determine the population prevalence of COVID and to study the biological, societal, and behavioral factors that affect susceptibility. So unlike clinical cohort studies that only include the more severe COVID patients, a population-based cohort like CanPath captures a fuller spectrum of patients. We were also able to capture the socioeconomic and mental health impact on the study population, and will be well positioned to ultimately study the long-term health effects. Next. The national leadership team, led by Dr. Philip Awadala, the scientific director, and Dr. John McLaughlin, whom you've just met, has secured funding for this research by CIHR, by the Immunity Task Force, and by PHAC. The research has several aims. First is the collection of COVID-related data from over 100,000 Canadians. Second is the longitudinal serological surveillance study of SARS-CoV-2 antibodies in Canadians. And thirdly, the deep sequencing to support genomic studies. Next. The questionnaire was designed to align with international efforts and was implemented in record time. So we asked participants whether or not they'd been tested for COVID-19 and what the test result was. We asked them if they suspected that they had an undiagnosed COVID infection. We asked about symptoms experienced, if any. For those who indicated that they had tested positive for COVID, we asked about details regarding the outcome in terms of whether or not they were hospitalized and the type of medical care that they received. There were questions about current health status, so a list of underlying medical conditions and risk factors for COVID-19, so whether or not they were immunocompromised, for example, and then other potential exposures of interest, so smoking and physical activity and cannabis use. We also asked about what their potential source of exposure might have been, whether it was contact with a direct case or whether they had traveled recently, for example. And then finally, we asked about the impact of the pandemic on their job status and on their mental, emotional, social, and financial well-being. Next. The questionnaire is web-based. Email invitations from the Ontario Health Study, the OHS, went out at the beginning of May, and the questionnaire just closed a couple of weeks ago. Cartagena from Quebec ran from June to July, and then the other cohorts followed. A few of the cohorts are still collecting data, but plan to close soon. So you can see that the response rates ranged from 23% to 70%. Interestingly, as you see, Manitoba's response rates are much higher than some of the others, and this is likely because the cohort is brand new and participants are more eager to participate, I think. Next. Over 95,000 questionnaires were completed as of a month ago, and we're now likely over 100,000. Maelstrom Research is facilitating data harmonization, which will be available for researchers by the end of the year. Next. Here are some of the preliminary results. The mean age of the participants was 63 years old. 11.5% tested positive for COVID, and that translated into 195 COVID cases and 21 hospitalizations. So these numbers, you'll note, are rather small, and they do hamper some of our questionnaire-based analyses of outcomes. We also had just under 3% reported that they suspected they had an undiagnosed case. And later on, when we launch into some of the seroprevalence studies, we'll sort of get a truer sense of what the true magnitude of the prevalence of infection was in the population. 52% reported that they experienced mild or severe symptoms, but remember, this was sort of a whole list of, some very specific and some very general symptoms, some that overlap with a lot of other conditions. And so we'll see, I'll show you how, not all of those symptoms are discriminating in terms of predicting whether or not someone was infected with COVID. And then finally, 25% of the cohort reported a change in employment status. Next. Cartagena published their findings in medRxiv after the first wave of the pandemic. And two of the public health messages that emerged from this paper were, first, that anosmia, which is the clinical name for loss of smell, is a major discriminant symptom for COVID positivity, whereas ear, nose, and throat symptoms seem not to be COVID related. And they suggested that some of those ear, nose, and throat symptoms should be, removed from the list of symptoms prompting testing. And secondly, their results emphasized the need of increasing the accessibility of testing for the general population at the start of the pandemic, when the results came out in Quebec. Next. The second wave of the pandemic that we're now in the midst of is unfortunately much worse than the first. Canada's first known case of coronavirus appeared on January 25th, and Quebec soon became the province most severely affected. Until late in the fall, BC and the Atlantic provinces generally fared the best in the country at controlling the virus until some restrictions were relaxed. The Atlantic provinces, however, have continued to require anyone entering from the rest of Canada to quarantine for 14 days. And that's been successful in keeping their rates low. So if you look at the bottom right-hand corner here, you can see the COVID incidence rates by province. So in PEI, for example, 1 in 1,880 people have been affected. In BC, it's 1 in 129. Alberta, it's 1 in 61. So you can see that even within Canada, there's been a lot of variation in terms of COVID incidence. And then if you look at the map, the size of the circles on the map correspond to the absolute number of people who have tested positive. The epidemic curve is showing a clear surge, a result of which, as a result of this, restrictions are being implemented across the country. Next. I'll now turn to the data that CanPath collected on precautions people were taking to see if we can provide any clues as to what could be driving this increasing transmission. So overall, post-pandemic life has changed for almost everyone. Participants have almost entirely used social distancing when out in public. They've washed their hands more regularly and avoided gathering in large crowds, and avoided going out entirely if it wasn't necessary. So 88% avoided leaving the house for non-essential reasons. Mask wearing, you'll notice here, on average during our data collection period ranked at 73%. It doesn't rank among the top few here, likely because it was implemented later. Some of these precautions varied a little bit by gender, with women more likely to adhere to some of them, but the differences weren't really too dramatic. Next. So here we see each of the precautions taken over time. The x-axis shows the number of weeks that have passed since the questionnaire was released. And it goes from the beginning of May, when the OHS was first launched, until the end of November, when the OHS closed, and some of the other cohorts are still collecting data. The y-axis shows the percentage of participants who are adhering to this particular precaution, and each line represents a different precautionary measure. So the top three are in line with public health recommendations. There's social distancing, mask wearing, avoiding gatherings, and hand washing. As you can see, the uptake in mask wearing, and that's the hot pink line, has increased in accordance with public health recommendations over time. So at the beginning, it was actually quite low. And that's when the public health wasn't really advising us to wear masks. It's just sort of hovering around 52%. And now at the end of November, it goes all the way up to over 90%. Wearing gloves when going out in public, that's the brown line at the bottom. That has decreased from over 30% to closer to 10% now, as people have become less worried about touching surfaces. And as we've learned, science has sort of showed us that it's less of a concern and you're less likely to become infected that way. Next. Here we can take a look at how participants may have adjusted some particularly important behaviors. So mask wearing, avoiding gatherings in crowds, social distancing, and limiting visits outside their household. For each behavior, there are 4 lines representing 4 of the regional cohorts that have harmonized data. So that's Ontario, Alberta, BC, and Manitoba. And a couple of things become apparent here. The first is that if you look at the blue line representing the Ontario Health Study, you can see a dip in the proportion of people complying with each of these precautions during August. And this was a time when the incidence rates were really low and people, I think, were feeling optimistic and more comfortable about returning to more activities of daily life. And the second thing is that if you look at the graph showing visits outside households, so that's the bottom right, over time and across all cohorts, we see a decrease in the percentage of people who are limiting visits outside their household. And what this suggests is that people are becoming complacent and perhaps feeling exhausted by the pandemic. And maybe this is the one thing that they perhaps find particularly onerous. The public health message here, though, should be that we need to continue to be cautious, especially leading up to the holiday season, and see every one of our contacts as a potential source of COVID infection. Next. The pandemic has exposed to 16% of the study population. Next. The pandemic has also exposed inequities in financial security. So unemployment rates have risen dramatically. About 8% of cohort members overall indicate that they lost their job. And that's sort of the on the left, and the red bar represents the white population. Ethnic minority groups were slightly more likely to have lost their job and to have incurred a reduction in wages or hours. They were more likely to have received government financial support to indicate that their financial resources don't meet their needs. And you can see that goes all the way up to 32% for Indigenous people, and that they worry about money in general. The last bar on the chart on the right represents the proportion of participants who received psychological support during the pandemic. So this could have been from a medical professional or from their community, family, friends, or colleagues. The proportion really across all ethnicities is high at around 20%. And I think that's a reflection really that this is a traumatic time. And even when the physical dangers of the pandemic recede, mental health issues could very well linger. Next. In terms of differences by sex, the indices of financial stress and loss of income or employment shown here were not significantly different, but these may widen as the pandemic wears on. Nationwide, we know that the pandemic has pushed women's participation in the labor force down to its lowest level in 3 decades. And women are overrepresented in certain industries most affected by closures, earning losses, and layoffs. So they comprise 61% of essential workers in our study. We did not note an increased risk for contracting the virus. So the odds ratio there was 1.2, and it was not statistically significant. And that's similar to what's being seen in other studies. But note that the current body of evidence does indicate that men are at a greater risk for critical illness and death. And that's a sex disparity that seems to be explained by that may be explained by women's more robust immune systems. Next. We asked a series of questions about access to healthcare, and these are the responses among participants who said that they were currently being treated for cancer. So 12% said that they had a surgery canceled or deferred, 10% had a treatment canceled or deferred, and 12% for lab tests. At the pandemic's onset, as you know, healthcare providers delayed and canceled all but the most urgent treatments and surgeries. Initially, it seemed worthwhile to keep people out of hospitals for their own safety, but data now suggests that continued cancer treatment doesn't seem to put people with cancer further in harm's way. 54% had a virtual appointment with their healthcare provider. For cancer patients, though, there's a risk of missing something important in a virtual visit. 9% reported facing a medication shortage, and 26% delayed seeing a healthcare professional about a problem or concern. So this last statistic is among participants currently being treated for cancer, but a similar percentage was reported for the study population as a whole. It follows that oncologists are deeply worried about the cancer patients who don't know that they're cancer patients yet, and studies suggest that the impact of COVID will be reflected in cancer survival in the next 5 or 10 years. Next. So the question now becomes, is it possible to predict, based on symptoms or exposures, who is likely to be COVID-19 positive and should be tested and who is not? So let's dissect this a little bit. So knowing whether you have COVID-19 is so complicated because there are so many different symptoms, many of which echo those of the flu or other sort of more general syndromes. And the most common symptoms in our study are fatigue, shortness of breath, loss of taste, fever, headache, and loss of smell. Fatigue, you'll notice, is the top ranked symptom. 86% of the population said that they had fatigue. However, obviously this is a very general symptom and was reported by many other participants, not just those who tested positive. Also complicating things is that this constellation of symptoms is so different between people. So the Cartagena group performed an analysis for identifying the combinations of symptoms leading to the most homogeneous subgroups with respect to being positive. And I validated these groupings in the OHS dataset to see if they were predictive here too. So we found that those who reported a loss of smell were 78 times more likely to test positive for COVID compared to those who had no loss of smell, no fever, and no headache. And that result was statistically significant. If you add headache to that, it becomes even more dramatic. So those who reported a loss of smell and a headache, compared to those who had no loss of smell and no fever, were at a 100-fold increased risk of testing positive. Loss of taste was significant, but less dramatically so. Sorry, there were people who reported a loss of taste had a 27-fold increased risk of testing positive, also statistically significant. And fever was associated with a 12-fold increased risk of testing positive. So the sign that most clearly distinguishes COVID-19 is that many people suddenly lose their sense of smell. They don't register even strong smells like onions or coffee. The formal name for this is anosmia. And not all virus victims get anosmia, but again, we found that 78% did. In contrast, the ear, nose, and throat symptoms, so runny nose, sore throat, hoarseness, sinus pain, and wet cough showed the weakest associations. At the bottom of the table, you can see that having contact with a COVID-19 patient was associated with a 41-fold increased risk of testing positive, and being a medical worker was associated with a 6.5-fold increased risk, and both of these were also statistically significant. Next. There's been a lot of interest around blood type and COVID-19 susceptibility and severity. The current body of evidence suggests that O and Rh blood types may protect against SARS-CoV-2 infection and possibly from severe illness. In terms of susceptibility, SARS-CoV-2 may be reacting differently to surface factors and antibodies. We also know that variants within the ABO gene are associated with a number of diseases. So it's biologically plausible that different blood groups might vary in their risk of being infected with COVID-19. Here are some of our data, but our confidence intervals here are really too wide to draw any meaningful conclusions. In terms of the implications, the effect size seen in other studies has been small and really shouldn't undermine the importance of other public health measures. Next. COVID-19 has been called a mercurial disease. So while some people experience only mild, fleeting symptoms, others are knocked over with a severe illness that can last several weeks. A minority of patients develop life-threatening complications, and we know that death can ensue. The reasons for this remain somewhat of a mystery, although certain risk factors for severe COVID have emerged. Immune response to viral infection seems to determine severity of illness. So if the immune system goes into overdrive, it can trigger this cascade of harmful effects. We know that immune function declines with age, and it follows that elderly people with COVID-19 are among the most vulnerable. So we found that the older age group, so people over age 65, were 2.2 times more likely to be hospitalized. These confidence intervals are wide. And again, this is a reflection of the small numbers that I pointed out at the beginning. I mean, we only had under 20 COVID cases who ended up in the hospital. And then the other issue with these data is that there could be a bias toward the null. So if older patients who contracted COVID ended up in the hospital were also more likely to die, they're going to be underrepresented here, and that will bias these associations toward the null. So some of these risk factors for severe COVID-19 are sort of better left to analyze after we do some of the administrative health linkages. Various chronic health conditions, various chronic health conditions have been associated with an increased risk of severe infection. We found a 3.6-fold increased risk for CVD, for example, and that was significant. And finally, obesity is now being recognized as the most significant risk factor after only older age for being hospitalized. And studies have shown that young adults with obesity appear to be at particularly high risk. Obesity affects 25% of our study population and was associated with a 3.5-fold increase in risk. Next. Most people will recover completely within a few weeks. So among the positive cases, 77% said that they felt completely or mostly back to normal. And if you look at the pie chart on the right, you can see sort of what the distribution was. 12% said that they were not really back to normal. 9% were a bit back to normal. And 2% were not at all back to normal. And then in terms of days to recovery, that there was also a range in that 17% recovered in less than 7 days, 30% in 8 to 14 days, 35% in less than a month, and 14% in more than a month. So first, we looked at sort of the group of patients who had indicated that they were still not fully recovered, and they had between 2 and 16 symptoms. Next. The long-term sequelae of COVID infection are largely unknown. These are just some from an even longer list of potentially long-term effects. And I think that the long-term effects of infection can be studied within CanPath through these administrative health linkages. And I'll explain some of that, and possibly further down the road with continued data collection and follow-up questionnaires. Next. I've mentioned that a significant benefit of CanPath is that participants have consented to linkage to administrative health databases, and these are some of the regional data holders in each of the provinces. So for all of the cohorts, we're able to link to the cancer registries, and cancer ascertainment, has a very high percentage of ascertainment completion. It's about 98%. So we can really accurately determine cancer status. And then there are different agencies across cohorts. So you can imagine that, linking all of these data would become challenging and sort of a lot of work to independently approach each of these organizations. And so a new organization has just been created to sort of help facilitate some of these linkages. It's called HDRN, the Health Data Research Network. CanPath has partnered with Health Data Research Network Canada to enable these linkages, and researchers can explore the data holdings available on their hub. So they have a website called Dash, and it's sort of a single-stop online portal that integrates all of the data from all of these different regions. We have a pilot project currently underway with HDRN to link data related to COVID and CanPath participants in BC, in Alberta, and in Ontario. Next. While we await this pilot project through HDRN, we've gone ahead and started the process of linking OHS data with data holdings from ICES. So here's a partial inventory of their data holdings. So for example, research on the long-term effects of COVID and risk factors for hospitalization, ventilation, pneumonia can be facilitated through these linkages. And then on the very right-hand section, there's an area here for project-specific research data, and this is where the linkage to the COVID lab results would fall. But it can really support, you can see sort of there's a vast number of research studies that could be supported through these administrative data linkages. Next. So here are the results from our linkage of the OHS to the Ontario Lab Information System. So here we're looking at the positive test results over time. The x-axis shows the week of the year. So starting in February, I think CanPath saw its first, or sorry, the OHS saw its first COVID positive case in early February. And then it goes all the way until just last week. So there's not very much delay. I received data that went all the way up until December 1st from them just yesterday. So there's, it might not have been 100% complete, but there's not that much delay in reporting. So here you can see, if you look at this curve, you can see that it really does mirror the epidemic curve that we saw in the population as a whole. And what that suggests is that the OHS is representative of the Ontario population in general. And that's reassuring in terms of our research studies. Overall, we had 535 participants who tested positive, and that's compared to the 120 who we were able to identify from just the questionnaire that we sent out. So the questionnaire that we sent out was completed by 40,000 participants, but the OHS is a really large cohort. There's almost 200,000 participants. So some people didn't respond. And some people, they filled out the questionnaire early in the pandemic, but their COVID status may have changed over time. So when we link to this lab information, that allows us to update their COVID positivity status. Also, for some participants, when they completed the questionnaire, they could indicate if their COVID result was positive, negative, or pending. And so some of them indicated pending. And with this data, it'll allow us to go back to that questionnaire and properly recategorize those people as either positive or negative and make use of the baseline data. In total, there were 91,938 tests conducted. So that to me seemed like a whopping number in a cohort of 200,000. But I'll show you in a second that there were some multiple tests per patient. And overall, 0.5% tested positive. Next, so these are so before we were looking at just the positive test results, and now we're looking at both the positive and the negative test results. So the darker line is just the negative, removing the duplicates. So some people, you need to sort of repeatedly test negative in order to be out of quarantine or go back to work. So a lot of patients reported that they actually had multiple COVID tests. The mean number of tests per participant was 1.9, but the range went all the way from 1 to 32. And the 32, I think, reflects the fact that in some workplaces now, people are being required to be tested daily. And that could possibly account for such a high number, 32. So there were almost 48,000 unique tests that were done over time. The pink line at the bottom shows the positive. So you can see it's really dwarfed by the number of negative tests. And in terms of capacity, 91,000 tests in this cohort of 2,000 suggests that we're doing fairly well at achieving capacity, or that people are being able to get tested if they want to. Okay, next. So I think all of those data really suggest sort of how powerful these linkages will be and how useful the OLIS lab results are going to be for future studies. CanPath and its regional cohorts are also conducting 2 seroprevalence studies. Both studies will collect dried blood spots using kits mailed to participants, which will then be tested for antibodies for the SARS-CoV-2 virus. The CIHR-funded study will test 3,000 randomly selected participants at 3 different points in time, 500 per cohort. So this sort of serial data collection will allow us to sort of measure whether immunity is waning over time, or what happens after vaccination over time. The Immunity Task Force funded another study that will test 20,000 targeted CanPath participants, including populations that are traditionally not included in studies or among the highest risk of exposure to COVID, and the people that are among the highest risk. So residents of long-term care homes, people living in underserved urban and rural communities with a high prevalence of COVID, for example. And both of these studies are using these dry blood spots kits that are being mailed to participants. Next. So there's a questionnaire that's being sent to participants, or it'll be a web-based questionnaire that participants are being asked to fill out that's accompanying the seroprevalence studies. And it includes some of the same questions that we asked before, and then a few additional important questions. We're asking more detailed job classifications for frontline workers likely to have occupational exposures. So passenger and delivery drivers, Uber drivers, restaurant and package delivery drivers, and then services requiring entry into private homes. So personal support workers, nurses, tradespeople, movers, cleaners, for example. Those, we didn't have any of that information in previous iterations of the questionnaires. And then we're also asking on this questionnaire information about COVID vaccines. So participants will be asked to indicate whether they've been vaccinated, if so, which vaccine they received and the date that they received it on, whether vaccines were available at the time that they provided their blood sample, and whether they're willing to receive a COVID vaccine if they haven't already, and if it should become available. So this will allow us to, assess the uptake of vaccines in the population, and also how immunity changes over time. Next. The last initiative that I'd just like to touch on is the COVID-19 Host Genetics Initiative, of which CanPath is a part. It brings together the human genetics community to generate, share, and analyze data to learn the genetic determinants of COVID-19 susceptibility, severity, and outcomes. And this model of data sharing is really unique. I mean, I think COVID has sort of changed the research landscape in a lot of ways. Traditional genetic consortia come together with the main goal of publication, only after which the results are shared. And here it's an alternate approach. So results are being shared immediately. Next. The epidemiologic risk factors that have been identified so far don't fully explain why some people have no or mild symptoms, whereas other people have severe symptoms. And through this host genetics initiative, 2 or 3 genomic regions that are associated with severe COVID-19 have been identified. The risk variants, though, confer a small increased risk for hospitalization, so it seems as though the genetic contribution is modest. Nevertheless, one of the leaders of this initiative said that their biggest accomplishment so far is in bringing this community together in the inclusion of researchers from countries that are underrepresented in large genetic consortia, such as Qatar and Brazil. Collaboration, he went on to say, is essential for battling a global pandemic, which brings me back to CanPath. Next. We have this unique Canadian research platform available to researchers, both national and international, and to trainees at recognized institutions. There's a wealth of data here that can be analyzed. Access is requested through the CanPath portal online, and the website's given there. And researchers can visit the CanPath website to view an up-to-date list of currently approved projects to see if there's any overlap with sort of what your research interests might be, and to read instructions for submitting a data and or biosample access request. Next. You can also explore, you can also explore the data available through CanPath on the portal. The national harmonized data from the COVID-19 questionnaire will be available by the end of December. And then if you go to the website, canpath.ca, you can actually see the questionnaire itself if you want to scroll through some of the details about the variables that we collected and see a list of the variable domains. Next. So this is just the application template that you can fill in online. Next. This is the usual access process sort of flow chart. And you'll note here that there are quarterly submission deadlines. So there's a full committee review. There are sort of some administrative steps, and then there's a full committee review that happens quarterly. But for people who are only requesting harmonized data, that can be expedited. But the entire process is further expedited for COVID research. Next. So given the immediate need for pandemic research, CanPath has revised its expedited review process even further to provide researchers timely access to the COVID-19 questionnaire data, and requests for the national questionnaire data set can be reviewed in as little as 9 days. So it's sort of record time for this study. Next. So there are a lot of people that we need to thank for making this all happen. First and foremost, the national leadership team who secured all of the funding necessary and got all of the instruments coordinated and in the field. Next. The National Coordinating Center. So the Coordinating Center is housed at the Dalla Lana School of Public Health at the University of Toronto. And here's everybody involved on that end. Next. A special thanks to the Ontario Health Study Team, the group that I work with. The OHS hosted not only the OHS web-based questionnaire, but the questionnaire for a few of the other cohorts, and a couple of them hosted their own. So thanks to the OHS study team for getting this all done, and really to the study teams from each of the individual regional cohorts. And thanks to Maelstrom Research for harmonizing the data. Next. To our sponsors and hosts, thank you. Next. And then a big thank you to the CanPath participants who generously donate their time. This whole cohort is a success because of their ongoing commitment to the study. Thanks very much.
Thank you very much, Vicky. Wow, quite remarkable work, and thank you for a very clear and comprehensive presentation today. To everyone who's participating, we encourage you to post your questions in the Q&A section of the Zoom call. There are a couple of questions here. I'll start with one from Regine Hung, who's asking if you happen to know, Vicky, the timeline of the serology test data availability. Any comments that you may have?
So, I mean, the serology studies are just being launched now. It's just going through ethics approval and the final study design. So I think that it'll be out in the field. I think that there's a pilot plan for December, and then it will be out in the field in the new year.
Excellent. So, and I can just add a little bit further to that point. Vicky's exactly right. First of all, I would actually comment too that even the work that you've presented today, Vicky, it's really quite remarkable to know that within about a 6-week period that 95,000 survey questionnaires were completed and the data were provided. And then here, really another 6 weeks later, you're able to present these data complete, even with, for Ontario, the linkage through to the ICES data. So things are really very much sped up, and that will continue to be true for the access to these data that Vicky's presented today. And she's given the timelines for that, but also the commitment by both our team, the CanPath team, and then the whole of the COVID immunity task force to try to make sure that during the course of the pandemic, solid evidence can be made available. There's a question maybe a bit more relevant for me to answer about whether REB for COVID analyses can be expedited or have been expedited. Researchers such as Vicky and others can get their ethics review done at their host institution right across Canada. It's I can't speak for all of those host institutions, but there is a commitment by most organizations to ensure that COVID is rapidly responded to, and that does include even the attention of REB committees. Did you have any comment further about REB or ethics review from your perspective, Vicki?
No, just that I found that it is very much expedited, and even if you send, sort of emails asking them to please speed it up, they really are amenable to such requests.
Mm-hmm. The one question here about the cost to access the data. There is information on the CanPath website about the through the access portal. For data-only requests, the costs for all of CanPath data are quite minimal, and then in certain situations, such as for COVID, and the cost structure has been reduced to ensure that the data can be made widely available. So I encourage people to go to the portal on the CanPath website for that. A question from Nicholas Burkett. Have you looked at the risk of COVID or severe outcomes in relationship to medications? Can you comment on that?
So we had data from the baseline questionnaires. I mean, there's a lot of interest in ACE inhibitors and ARBs and whether or not they provide a portal of entry for COVID and increase the risk of infection. And I didn't find a statistically significant association. But again, I think that's something that could be repeated with some of the linked data and maybe some of the data from our baseline questionnaires just to increase study power.
Mm-hmm. Thank you. Just while we're waiting for additional questions, I could ask one. First of all, for those very large numbers from the linked data, that really is quite remarkable to see what you were able to obtain by looking at the linkage to the Ontario Laboratory Information System with the Ontario subset. Can you comment at all about the expectations that you might have, or with your colleagues, the possibilities and the timelines for linked data from the other provinces is the first part of the question. And then the other one is whether other provinces would have similar type of laboratory information.
So they do. I mean, this is part of the pilot project with HDRN. We haven't sort of attempted to approach these data holders independently, I don't believe. But I know that at least a couple, Alberta, definitely you can link to lab results, and a couple other cohorts. I'm not exactly sure which ones, but it's definitely a possibility.
Thank you. And then again, for the listeners to be aware of today, then part of the structure of CanPath and the fact that it is based in individual provinces, it does really enable a deeper dive in some provinces for certain questions. And then that it gives a particular distinctive feel. But those OLS data that you were able to report on were really quite striking. There's another question here, Regine Hung again. Will there be data on disease severity, e.g. respiratory support, number of days of hospitalization?
So we asked exactly that in the questionnaire. What exactly happened when they went into the hospital, what treatments they got, how long respiratory treatment, and whether it was necessary. It was just that the issue there is just that the number of cases was small. So again, even across all the harmonized data, I mean, we're still sort of waiting for some of the questionnaires to close, but we only had 22 participants who indicated that they'd been hospitalized. And again, there's a little bit of a bias going on there because some of the people who ended up in the hospital and have had severe infection, might not be the ones who are coming to complete the questionnaire. But I think that that's where, again, where the linkages are going to be really powerful, because absolutely we can ascertain those outcomes using hospital admission and discharge data. And that will provide an unbiased, more fulsome sample for analysis.
Okay, thank you. Several points are coming up here. I thank Sasha Bernetsky for making the comment about sort of some parallel but more immunization focused work that's going on in Canada. And she's encouraging a get together or collaboration there. And in particular, akin to, in a way, to what you've described, Vicky, about the value of the laboratory testing linkage. Can you comment on whether it would be valuable to be able to to link CanPath to a future vaccination registry, should it ever exist, which is what Sash is referring to?
I mean, absolutely. I think if that were possible, we could, trying to think of what the research uses would be, but I mean, we would know what the uptake was in our population. I mean, we would have even though we're sampling 3,000 or 500 participants to see the seroprevalence, it's sort of a moving target. And depending on when the blood sample is sent in, they might have already had the vaccine or not. But if we were able to link to some kind of national registry, we would really have a better indication of the percent of the Canadian population in general who've been vaccinated and whether or not that's high enough to achieve herd immunity.
Yeah, thank you. And similar point raised by Michelle Caterchio. I think the CPHA members who are across Canada involved at the front line of public health, know that all of us are committed to vaccination and immunization, but there are some challenges of linking such data from one province and to another province, and to wrap that up for all of Canada. There are some data systems, but to do the types of linkage and to collect a full vaccination history, it is presently a bit of a challenge. But who knows? Maybe COVID will create the initiative and focus to actually enable such a registry to be created. On the chat line, there's a question from Mary Alice Harvey. So, is there a way to extract the asymptomatic people who tested positive from those who tested positive with symptoms? So, people who had tested positive for COVID, asymptomatic versus symptomatic. Can you comment on that?
So, the problem with that is that a lot of the asymptomatic people didn't go on to be tested, particularly early on in the pandemic. So sort of the subgroup that I see in which we could study that is somebody who sort of said that they had exposure to a COVID-19 case, or they worked in a high risk field, like they were a medical professional. They reported no symptoms and they went on to get studied. So that's sort of a very defined subgroup in which you could do a study like that.
Yep, thank you. Somebody's asked the question, there seems to be a somewhat smaller number of confirmed COVID-19 cases amongst the responders. What are your thoughts on the limitations that it would impose and ways to overcome this issue? So I think you have commented on this in some ways related to certain biases that you've considered and taken account of. Any further comment to that question?
I mean, just that, the numbers are low, but you actually sort of have to calculate, an incidence rate where people's contribution is censored at the date that they filled out the questionnaire. So remember, for Cartagena, for example, there was only this 1 month window. So, yes, the numbers are maybe low, but it doesn't mean that they're lower than the population incidence rates. And then, we did for the OHS go back and send an email to people, a targeted email saying, if your COVID status has changed since you first filled out this questionnaire, or your health status in general, please complete it again. And about 1,000 OHS participants did. And some of them on the second iteration did report that they had a positive COVID test, and those have not yet been incorporated. I mean, the numbers still are small. Really it's the linkage through the OLIS results that is going to generate the really full, complete picture. Thank
you. Maybe you can best answer this one with regard to the Ontario Health Study, where you're directly working right now, but somebody's asked whether there will be another COVID-19 survey after the one that you've reported on.
So there's this one, and then there'll be the one that's accompanying the seroprevalence studies. Yes, yep. which repeats a lot of the same questions for some of the participants who didn't complete the first COVID questionnaire. And then it has all of the additional information about vaccines. So that will be the first opportunity really to study, you know, whether people are willing to take a vaccine, the brand of vaccine that they took, if there are multiple ones available, the dates. I mean, I think that will be a really interesting source of data.
So, and just from an overall scientific and research platform perspective, for people to be aware, just as you've said, that's one of the unique advantages of a really massive Canadian cohort, is that we can actually, as things change, send out to these participants another questionnaire. It's all based on whether there are resources available, and we have to always respect the participants themselves and any burden that they would have. But this type of platform can enable the type of work that people are asking about. A question here about, have you looked into the relationship of pre-existing mental health or depression on the number of confirmed, suspected, or probable COVID cases?
No, so we haven't explored that yet. That's a great research idea that's wide open, if that's your area of interest or expertise.
And just as Vicky is, as she's answering to that, one of the purposes of today's presentation isn't to necessarily answer everything about COVID, but to let people know that these data exist, and we encourage researchers to seek access to the data which are basically coming online. And a question like that, or the questions about medications, these are all things that people with particular skills and interests in those areas, we encourage you strongly to seek access to the data, write those papers. Those are important questions that need to be answered. Roy Gillis has said, thank you for a wonderful presentation on an amazing research group. Given the broad range of coverage of research topics related to COVID, what would be the important original socio-behavioral data collection projects that you think are most important to conduct now? So I think that's a question about what other things could and should be done from your perspective.
Well, I think, you know, the next questionnaire that we're sending out will sort of really identify people maybe who are resistant about vaccine uptake. And it will be really interesting, I think, to identify what subgroup that is and then target them for public health interventions.
Sure. There's Michelle Caterchio has raised something about, she wasn't really intending to ask about necessarily COVID vaccination, but about all vaccination history. So we answered that partly before. If there was a vaccination registry, those types of questions about all other vaccine exposures or experience could be addressed. Do you have anything else to add to that question, Vicky?
No, just that on an individual level, we don't have self-reported data on vaccinations.
Correct. Okay, but it is part of the future of building up Canadian data systems to answer these important kinds of questions. I am mindful of the time. We're kind of wrapping up. Greg, I'm not sure if you would like to come back on and speak from the CPHA perspective. And just while Greg's coming back on, I'd really like to thank everyone for your attention. Dr. Kirsh, beautiful presentation, great work done in real time, very rapidly and very clearly presented. So thank you. I think we all applaud you for that. So thank you. And then again, to all of the, to CPHA, it's been very important for us to work with you to present today. Over to you, Greg.
Thank you very much, John. And thank you to Vicky for the great presentation. And John, thank you for moderating the questions. We very much appreciate you presenting this work. And I think data comes up across almost every topic area in public health that what we have and don't have. And I think connecting people is very important. I want to thank all the participants for the questions you asked, and we very much appreciate your engagement. So this webinar has been recorded. It will be posted on CPHA's YouTube channel, and links to the slides will be on the CanPath, and a link obviously to that. So that will go out to everyone who registered. And with that, we will end today's webinar. And thank you, everyone, and enjoy your day. And breaking news, if you haven't been looking at the news, Health Canada has approved the Pfizer vaccine. So,
great.
Take care, everyone.
Take care, all. And
Thank you so much.
great work, Vicky. Yeah, nicely done.
Take care.